Hey, good afternoon. This is Christopher South with Metro Area Ambulance. And I'm kind of out of uniform today because it is one of my off days, but I wanted to come back up to the shop and record about rapid sequence intubation and really just get the feel for where this happens at. As a lot of us get our intubation education in a very clinical environment. You probably got most of your intubations done at either an OR or you did it like we do it here is by using a mannequin. But what I want to talk about is rapid sequence intubation, and it's a little bit of a misunderstanding on what RSI is I want you guys to be able to understand to take the R out of rapid. What we're actually trying to accomplish here is to take over and manage that patient's airway. So guys and gals, if you'll join me, this is rapid sequence intubation. All righty, folks. Let's talk a little bit about rapid sequence intubation. All right, folks, let's do a quick airway anatomy review. And let's start. This picture would be a little bit more appropriate if it was actually inverted, if it was turned upside down, because when we're looking at the airway for us, when we put the laryngoscope inside of the patient's mouth, this is the view that we're going to get is actually going to be inverted. So the first thing that we're going to see as we place the laryngoscope is we start to slide it down to over the tongue, past the base of the tongue, past the lingual tonsils, and we're going to see the glottic fold, and then we're going to see what we're really looking for, which is the epiglottis, which is going to be that meaty tissue that folds over and prevents food from going down into the trachea and actually allows it to go into the esophagus. So what we're looking for is that anatomy. So once we find the epiglottis just a little bit south of there, we're going to see the vallecula, the vocal folds, which are known as the true vocal cords, and the trachea, which is that nice opening. And that's what we're looking for. We're looking for that anatomy. So folks, if you can find the vallecula and the epiglottis, you should be able to see the anatomy clearly to be able to grab your tube and to intubate. So one of the things I want to encourage is if you can't see those true vocal cords, if you can't see the opening of the trachea, don't just stick whatever. We as advanced providers, we should not be just poking and hoping. All right. We want to make sure that that tube is going in. So one of the things that we're going to do when you guys come out to the lab and do that hands-only thing is we're going to talk a little bit more about one of the most common issues that we have with intubation is actually intubating and going into the esophagus. So if this happens, a lot of you guys may have been taught to pull the tube out and retry. Well, folks, there's only two holes in there. So if you have placed a tube in the esophagus, you know you've got one in there. So why not leave that tube in place and grab your other tube, go back and look, and you should have an easier time actually placing the endotracheal tube into the right space. As we look more into our anatomy, we can see the nasal space is actually a big area of the anatomy that's hardly ever used. But as we're intubating, we're opening the mouth. We have to worry about the teeth that could be in the way. They could have buck teeth. They could have potentially broken teeth from trauma. We have to worry about the tongue, which is in the oral cavity, and it's going to cause us a lot of obstruction. So one of the things is we want to make sure that we have an understanding that the tongue is the largest obstruction in the airway, and we have to manage that as well. And I want to encourage everybody, as you can notice, the hard palate as it extends back turns in to the soft palate. Make sure that you are putting a water-soluble lubricant on your tube. That way we can prevent any kind of trauma due to intubation. So this is a better view of what it actually looks like when we're intubating, so we can see the epiglottis. So we're going to catch that, and we can see those true vocal cords. And that's the trachea. That's exactly where we want to be sticking our tube at. So, folks, when we are thinking that a patient is going to need rapid sequence intubation, that we're going to take over that patient's airway, we have got to have a plan. We've got to have a plan in place in order to take over this patient's airway. This is not just a dilly-dally event where we just start grabbing stuff and hope for the best. This is not like in a cardiac arrest. We are taking over this patient's airway. It's thoughtful, and since we're putting thought into it, we've got an opportunity to do it right. But we can predict how difficult an airway can be by simply remembering the mnemonic LEMON, LEMON. And LEMON stands for L is for look. We're actually looking at that patient. Do they have a short, thick neck? Are they morbidly obese? Do they have a dental overbite or buck teeth? All of those things could indicate that this patient may be more difficult to tube than others. E is evaluate, and this is known as the 3-3-2 rule. The mouth should be at least 3 fingers wide open. If you can get their mouth open and get 3 fingers in, all right, the space from the chin to the hyoid bone should be at least 3 fingers wide, and the distance from the hyoid bone to the thyroid notch should be at least 2 fingers wide. If that patient has any kind of range outside of the 3-3-2 rule, it can indicate that that patient is going to be more difficult to intubate. M is for Mallampati. So Mallampati is when we open up the patient's mouth wide and we actually look in. And class 1 means that we have complete visualization of the soft palate. We can see the anatomy all the way down to the soft palate. Class 2 is we can see the visualization of the uvula. Class 3 is only the base of the uvula is present right there at the top. And class 4 means it is completely not visible at all. We can't see anything. The higher the score, the more difficult we think the airway may be. O is for obstruction. We can have foreign bodies, especially in trauma, but also we don't know, especially guys on the critical care side, when we land and we go to a hospital, we may not know exactly what we're getting into. Have they made previous attempts at intubation? Did the patient come in and maybe swallow some food? We don't know what kind of obstruction it could be. They can have an obstruction due to obesity. They can have a hematoma. There could be masses, all kinds of things. And if they do or are suspected, we need to be able to manage that. N is for neck mobility. So the ideal position for intubation is a sniffing position. And once you guys come to lab, we're going to see some different techniques from getting them in a sniffing position besides just manipulating the neck. We're going to look at tilting the stretcher 30 degrees. We're going to look at some different padding methods that are going to make visualization of the anatomy a lot more easier. So some of the complications we can see with neck mobility is in trauma patients when we're having to keep them cervically immobilized with a C-collar. Older patients, okay, their necks are not going to bend as much as the younger folks. And we can have nuchal rigidity. We have different disease processes, but we can also have nuchal rigidity in some of our special needs populations, especially folks that have things like Down syndrome, for example. So now we're getting ready to actually place the tube into the patient. Once we've made that conscious effort and that conscious choice that we are going to prepare to intubate, we've got an opportunity to get all of our equipment and to get everything right, including our team. So one of the things that I like to do, if I'm fixing to RSI, whoever's in the truck with me, whether it's the fire department, whether it's my partner on the aircraft, whether it's the people there at the hospital that we go to, we're going to talk about exactly what we're going to do. We're going to get a plan in place. And once we get our plan in place, we're going to execute it and we're going to be successful because we've communicated our plan. We've got all of our processes in place. And once we've done that, we're set up for success. So here's the basic equipment that we're going to need. The first thing is proper protective equipment. And especially in the COVID age, we got to make sure that we've got our respiratory protection. We've got glasses or goggles to protect us from any kind of fluids that may splash. We've got our gloves on and our gown as well. ET tubes. You need at least 2 ET tubes. You need the size that you predict you're going to go with, and also one size smaller down. Make sure that your ET tubes, both of them, have a stylet in it. Make sure you have laryngoscope handle and blades. Make sure that those handles are that the handle has good batteries in it. You've tested it. When you get your blades out, make sure they're white, bright, and non-flickering. Your suction equipment should be set up and turned on and running and next to the patient. You should have a 10 milliliter syringe for each tube. You should have a gum elastic bougie. Water soluble lubricant, there should already be pre-lubed on those ET tubes. Make sure you have a tube holding device, a bag valve mask that is already connected to oxygen and turned on. Make sure that you have an oxygen source that is turned on and running, a stethoscope, an end-tidal CO2 detector that is already plugged into the monitor, McGill forceps, and a rescue airway device. And when I'm talking about rescue airway device, is more than just having an iGel, a King Airway, or something similar. I like to not only have that, but I like to go ahead and have my trachea equipment as well. And so if I do have to do a crike there in the field, I've got it ready. I'm not searching for it. So we want to make sure that we have our neuromuscular blocking agents, our sedative agents, our syringes, our needles, our flushes, our IV stuff already set out. And we want to make sure that when we're drawing our medications up, we're going to lay it out and we're going to put it in the order that we are going to push those meds. Don't just throw syringes out there because we can get the order wrong. So place those syringes in the order that you are going to push them. So here are our pharmacy agents that we're going to be using to perform RSI. So let's take a look at sedative or induction agents. So benzos, such as midazolam, lorazepam, and diazepam, they are significantly longer duration of action and ability to cause hypotension makes them less attractive for RSI, but they are appropriate for sedation after intubation in the hemodynamically stable patient. For these meds, I try to use those post-intubation rather than as an induction agent. But if you are going to use these meds, midazolam is between 2 to 5 milligrams, lorazepam is 0.03 to 0.06 milligram per kg, and diazepam is 0.3 to 0.6 milligram per kg. Better drugs and better options are going to be ketamine and etomidate. So ketamine, the dosage is 1 to 2 milligram per kilogram. It has a very stable hemodynamic profile and bronchodilator properties. Etomidate, we're going to run it from 0.2 to 0.6 mg per kg, has a rapid onset, short duration of action, and very stable hemodynamic profile. Etomidate is one of my go-tos when it comes down to a sedative for these patients. So let's take a look at our neuromuscular blocking agents. So one of our big depolarizing ones that we're going to use is succinylcholine or SUX. And the dosage for that is 1 to 2 milligrams per kilogram. It has a rapid onset with a short duration of action. Some of our side effects is fasciculations, hyperkalemia, increased ICP, worsened bradycardia, especially in children. We want to make sure that we are using atropine with those children. We can also have possible malignant hyperthermia as well. So non-depolarizing neuromuscular blocking agents include vecuronium, which is 0.15 milligram to kilogram, rocuronium, 0.6 to 1.2 milligram per kilogram, pancuronium, 1.1 milligram per kilogram, cisatracinium, 0.15 to 0.2 mg per kg, and atracicurium, 0.5 mg per kg. All of these are going to have prolonged paralysis with long-term use and can cause hepatic dysfunction. The thing that everybody needs to understand is there is no effect in the level of consciousness when giving these medications. So when we give this, if this patient is not properly sedated, they are going to know what's going on, and it can be quite painful and very discomforting for that patient to be on a ventilator. Must be used with adequate anesthesia, analgesia, or sedation. So these same agents can be used for continued paralysis. We can give VEC 0.01 to 0.1 mg per kg, rocuronium 0.1 to 0.2 mg per kg, pancuronium 0.015 to 0.1 mg per kg, cisatracinium 0.03 mg per kg, and atracurium 0.5 mg per kg per hour. So other meds to consider is one of the opiates that I like to give is fentanyl, which is 2 to 3 micrograms per kilogram. I like to kind of start off with giving that prior to starting sedation and everything else. If we're going to be intubating a child, To prevent bradycardia right when we're about to give succinylcholine, let's administer 1 to 2 minutes prior to sucks and attempting intubation, and the dosage for atropine is going to be 0.02 milligram per kilogram. Prior to intubation, we want to make sure that we pre-oxygenate, and there's a couple of ways that we can do this. One of the procedures that I like to do is I like to take a nasal cannula, put it into the patient's nose, and run it at between 10 to 15 liters per minute and get good oxygenation while I'm intubating. One of the other techniques we can do is to place a non-rebreather mask on. If the patient's able to, is to draw some deep breaths in. Or we can start by ventilating the patient with 100% oxygen and getting good oxygenation. We want to get that saturation up as high as we can prior to intubation. But we want to make sure that we resuscitate before we intubate, because if we don't have these problems taken care of, we're not going to fix anything. So have we considered potentials for shock? Is bleeding controlled as best as we can do it? Is that patient hemodynamically stable? If they're not hemodynamically stable, have we considered some things to make that patient stable? Have we provided enough oxygen and ventilation to make sure that we are improving those saturations? What about rate and arrhythmia? Is their heart rate too low or too fast? Is there a medication that we can consider? Are they hypotensive? Should we consider a pressor? Are they hypothermic? Let's do some active rewarming, right, to get this patient warm. We need to consider all the peri-arrest causes that could happen, all these different things that the patient could be possibly in shock or going into shock. We need to correct them prior to intubation, because if not, the actual process of intubation could cause them to go into cardiac arrest. So let's fix all this stuff first. So let's resuscitate before we intubate. So folks, this is the end of the didactic portion of the rapid sequence intubation course. What I would like for you guys to do is to make sure that you come by and take the practical. What we're going to do is we're going to actually RSI, and we're going to make sure we understand drug dosages, and we're also going to look at some basic ventilator settings as well. So folks, thank you so much for listening. I hope this video helps you get a little bit of a greater understanding about rapid sequence intubation, and I look forward to meeting you in person. Thanks so much. Have a fantastic day.